Welcome to the webinar, Evaluating New Therapies in HIV. This program is jointly provided by North American Center for Continuing Medical Education, LLC, and DKB Med, LLC. This webinar is supported by an educational grant from Gilead Sciences, Inc. I'm Jim Kenny, Manager of Specialty and Pharmacy Contracts at Harvard Pilgrim Healthcare. Also presenting with me is Dr. Laura Kogelman from Tufts Medical Center in Boston, and we will be your presenters today. Here is our disclosure slide. Our goal in speaking with you today is to provide an opportunity to compare newly approved medications to their older counterparts and discuss safety and efficacy of both, discuss both in-development therapies and fixed-dose combinations and their role in long-term HIV treatment, and evaluate shifts in focus of the newly updated HIV treatment guidelines to recognize changes in the HIV treatment population and the impact on specialty pharmacy. I will now turn the presentation over to Dr. Kogelman.
Thank you, Dr. Kenny. My goal in speaking to you today is to review some of the basic background of HIV and where we stand with the HIV epidemic in the United States at this point in time, to discuss the current guidelines for treatment of HIV, and to discuss some of the newer agents that are coming down the pike and how that will change our management going into the future. This first slide reviews the current guidelines for HIV testing. These have been out since about 2013. These reflect the U.S. Public Service Task Force guidelines. Other agencies have come up with fairly similar guidelines. The age range varies slightly from group to group, but the general recommendations are pretty similar. The idea is that all adolescents and adults between the ages of approximately 15 to 65 should be screened at least once for HIV infection. Anyone who's at higher risk, if they're younger than 15, or those who are older than 65, if they have certain risk factors, should certainly also be screened. The idea behind this is really just to make sure that everybody gets at least one HIV test at some point during their contact with medical care. All pregnant women in every circumstance should be tested for HIV during each pregnancy. Those who present very late in care, even during labor, should be tested at that time. And individuals who are at high risk for HIV, even if they've been tested earlier in their pregnancy, should be rescreened towards the end of their pregnancy. How often we should rescreen is something that hasn't really been determined, and that's when it does get a little bit more into risk factors. For certain individuals, screening every 3 months, every 6 months, once a year may be appropriate. Other individuals should be screened maybe just once. The idea of getting away from focusing just on targeted screening and just making it available to all individuals. And the guidelines also support the concept of opt-out testing, which is really that you're seeing your patient, you offer certain routine tests, cholesterol level, thyroid level, and HIV, unless the individual specifically does not want to be tested for HIV. In certain states, including Massachusetts, we don't have opt-out per se, we have opt-in. It ends up being a slightly semantic difference. But the whole idea is making HIV testing routine as part of normal care for all individuals. Why we've moved towards this is that we realized when we focused in on targeting testing as opposed to routine screening, we really were missing a lot of people. Sometimes patients won't disclose their risk factors to their provider. Some providers may not be comfortable probing into those more sensitive matters, and some individuals don't even know that they're at risk for HIV. If we're asking for risk factors, we could miss up to 25% of HIV-positive individuals. And if we're missing those individuals, we're not getting them on timely treatment, we're not improving their health, and we're not preventing them from transmitting to other individuals. Most patients in a lot of studies have really been much more accepting of routine HIV testing rather than targeted testing, and it makes it much easier to do. The other reason to try to screen people as opposed to doing this targeted testing is getting people diagnosed early. With prior testing strategies or places where they're not really engaged in early testing or screening, many HIV-positive individuals may already have AIDS by the time they're tested. As you know, HIV has a long latency period. It takes a long time for HIV to progress to the point where you're at AIDS where the CD4 counts are less than 200. And by that point, you've lost a lot of time where you could improve the health of an individual. If we identify people early on in the course of their illness, it can lead to per-person survival benefits of over 11 years. It also decreases the chance that they could potentially transmit to other people. And HIV is a very different disease than it was 30 years ago. It's no longer a death sentence. It really is just a chronic illness. There are 6 classes of antiviral agents with 40 different products available. The HIV meds are far better tolerated than they used to be. There are fewer tablets. There are up to 6 single tablet regimens currently available, with more coming down the pike. They have better long-term efficacy and really have improved the life of people living with HIV. The other concept that I was alluding to is HIV treatment as prevention. So not only do we want to treat HIV early to prevent long-term complications associated with this infection, but we also want to prevent individuals from passing on HIV to their partners. There's been several studies that have focused on this, and we know that early initiation of antiretroviral therapy can significantly reduce the risk for HIV transmission to uninfected partners. One of the seminal studies was HPTN-052, and this studied serodiscordant couples in Africa, so one person was positive, one person was negative, and in individuals who were started on HIV treatment early, very soon after they were diagnosed, it reduced the rate of transmission by 96%. So really quite remarkable. Another study called the Partner Study, which included both heterosexual and homosexual partners with one person positive, one person negative. There were no linked transmission over follow-up over 1 year per each serodiscordant couple if the HIV positive partner was virologically suppressed. That means if a person takes their HIV meds reliably, the viral load is undetectable, the likelihood of them transmitting to their partner is extraordinarily low. We can never say it's zero, but it really is markedly diminished. And this, of course, in the real world is important not for the partner that they're with who knows that they're HIV positive, but if individuals have multiple sexual partners who may not know their status, this is preventing transmission to all those individuals as well. So the guidelines have really reflected this data, continue to support the idea that not only should HIV treatment be started in individuals to help their own individual health, but should be started to prevent transmission. So where do we stand with HIV in the United States? Approximately 1.1 million people in the US have HIV. About 15% are unaware of their diagnosis. Now, about 4 or 5 years ago, this number was closer to 25%. So I do think that the drive for more routine screening really has helped. More people are being diagnosed, but we still haven't gone down to zero. In annual incidence is about 39,000 cases. This also has decreased slightly. It used to be closer to 50,000, so we are making some progress. The annual new infections declined by about 10% from 2010 to 2014. The population is still at high risk. There are some significant disparities. So young gay and bisexual men, especially those who are African American, are at the highest risk for getting HIV compared to other groups. Looking overall where HIV positive adults sort of fall, in terms of categories, it's still predominantly men in the United States. It's different in other parts of the world, but it's about close to 75% of individuals with HIV are male. In terms of age range, we see the largest cohorts are in that 50 plus years, which is because people are living much, much longer with HIV. We're seeing an aging population with HIV, but there still are quite a few in the younger age range. And we know in terms of new diagnosis, we're seeing a lot more diagnoses in the younger population. So the individuals who bear the biggest burden of disease in the United States are predominantly men who have sex with men. And then in terms of race and ethnicity, we see a large population who are Black and African American, as well as Hispanic and Latino. Although the numbers of whites look significant on this particular graph, when you think about the actual demographics of the United States and how many individuals are Black or Latino, there really is a large disparity there. We talk a lot about this concept of a cascade of care. So, and this has been promoted in other fields as well. We're seeing it spoken about a lot in hepatitis C. The idea is getting these people appropriately diagnosed, getting them into care, having them stay in care, and getting them successfully treated. So as you can see, we're still missing about that 15%. So we have 85% of people who are actually diagnosed. We lose about 20-odd% when we actually get them into care, to receiving care. We lose another percentage when they're to get them to stay in care. And then once people stay in care, because the meds are really, really effective, most of those are virologically suppressed. Once they're in care, once they're seeing their doctors, once they're on meds, they're going to do well. But the issue is trying to get those people into care and get them to stay in care. And this is a challenge that's being addressed in a number of different ways. I think most people have seen a graph like this at some point. It really is remarkable that at the dawn of the HAART era in the 1990s, when all of a sudden we had protease inhibitors, people just simply stopped dying, which was really amazing to see this huge change in such an abrupt fashion. And now we have a very, very large population of people aging, generally living healthfully, but a large population who are HIV infected. And we're dealing with an aging population dealing with routine healthcare, hypertension, diabetes, things like that, but a huge shift from where we were many years ago. What are we seeing in terms of morbidity and mortality now that we have such effective treatments? The life expectancy in patients started on effective antiretroviral therapy early in the course of their infection, when they still have high CD4 count, really approaches that of HIV negative individuals. And this has been shown in several different studies. Mortality in most situations is not really directly AIDS related. We're not seeing people dying of PCP and toxoplasmosis and those kinds of things like we used to. We're seeing other consequences of having ongoing viral replication. Having this chronic inflammatory state has been linked to other consequences, such as an increased rate of malignancies. And this is not just AIDS-related malignancies, but also non-AIDS defining malignancies, breast cancer, lung cancer, prostate cancer, all these kinds of things we tend to see in a slightly younger group compared to their HIV negative cohort, and usually with more advanced disease. We see liver failure, which is usually associated with co-infection with hepatitis C, although fortunately that's shifting with the incredibly effective meds we have available for that now. Non-AIDS related infections, cardiovascular disease. As I said, HIV is an inflammatory state that can lead to early onset atherosclerosis and lead to cardiovascular consequences. Because HIV gets into the cerebrospinal fluid very early on in infection, we do see some ongoing effects onto neurocognitive function, and we do see some of our individuals, especially if they were infected a long time ago, where they had ongoing viral replication, we're seeing earlier onset of neurocognitive decline. So where are we now in terms of what we have to treat HIV? The recommendations were updated just this October. They just came out. The general recommendations for treatment haven't changed that much over the last couple of years since they were updated. The biggest shift was about late 2015 to 2016, this definitive statement that all individuals should be started on antiretrovirals, regardless of their CD4 count. We no longer focus on a specific cutoff to initiate treatment, and this really comes from a number of different factors. So there are a couple of major studies called the START study and the Temprano study that looked specifically at this question. If you start people when they have high CD4 counts, how do they do compared to people where you hold off a little bit? And these are CD4 counts of 500. These are not low counts where people are close to having AIDS. And across the board, they saw that people did better the sooner they were started. Fewer incidents of cardiovascular events, fewer malignancies, and we really saw that it was beneficial to start patients early. The other reason this has started to shift is that the meds have gotten so much better. They're so much simpler to take. They have far fewer side effects than they used to, and they're also much more potent. We're not worrying as much about people breaking through their regimens, developing resistance, and having to deal with those consequences down the line. So this has really shifted the approach to HIV treatment. As I said, the other indication for treatment is to prevent transmission to other individuals. But of course, you have to approach each individual on a case-by-case basis. Although the guidelines may say they should start, a lot of HIV positive patients have a lot of other issues going on. They may suffer from homelessness, from depression, addiction, all these kinds of things, and you have to make sure that all those other issues are managed before you can successfully start a person on therapy. They may be eager to start, but if they can't come to every appointment and have their numbers checked and make sure that they refill their meds consistently, it's not going to be beneficial to them in the long term. So we follow the guidelines, but we have to still approach each person as an individual. If a person does not have any other major psychosocial issues blocking their treatment, but maybe they're a little hesitant to start because they say, well, my CD4 counts are still pretty high, there are a couple of things that may push you a little bit more to try to encourage your patient to start therapy. So if they have any kind of symptoms related to HIV or AIDS at all, that would be an indication to treat. Even if their CD4 counts are high, if they're having significant weight loss, fevers, night sweats, lymphadenopathy, any kind of AIDS-defining illnesses, even if it's happening at a CD4 count that's much higher than you would expect, that person really needs to start on therapy. Individuals with very high viral loads really should be encouraged to start sooner rather than later. Rapid declines in CD4 counts. So maybe you tested them the first time and their CD4 count was 1,000. 3 months later, it's 800. You really want to get those people onto therapy because clearly the disease is progressing. If they have active hepatitis B or C co-infection, those patients should be started. Hepatitis B, because most of the drugs that treat Hep B also treat HIV, so you don't want to put them on a regimen that will treat their Hep B but only partially treat their HIV. Hep C, in general, people respond better to the medications. They develop less fibrosis if they're starting antiretrovirals. Individuals who have cardiovascular disease or at high risk for cardiovascular disease should generally be started sooner rather than later because of the inflammatory state that I mentioned before. People who present with very early onset HIV, primary HIV infection, acute infection, stopping the virus from progressing from more cells from being infected, halting that whole process is beneficial. So starting these people sooner rather than later helps. Persistently undetectable viral load without antiretrovirals, these are people that we refer to as elite controllers. So their own immune system is able to control their virus. There's always been a debate about what to do with these folks. Most people would probably start them on therapy. If there's a debate, if the CD4 counts are slowly declining, that would be a person you'd be more likely to want to start sooner rather than later. HIV-associated nephropathy, really the only treatment is HIV therapy. Pregnancy, of course, all pregnant women get started on antiretroviral therapy, and they continue antiretroviral therapy after they deliver. And age greater than 60 because of the other comorbidities that we've discussed before. There's a lot of medications available, as I mentioned before. there's technically more than 6 different classes of drugs. One is not an actual antiviral agent. It's what we call a pharmacokinetic enhancer, which I'll discuss in a minute. There are 40 different products, including 6 single-tablet regimens. The categories include the nucleoside or nucleotide reverse transcriptase inhibitors, and they do exactly that. They block the reverse transcriptase from transcribing the RNA. NNRTIs act on the same enzyme, but they do it slightly differently. They actually physically block the transcription. Protease inhibitors block the functional proteins from being formed appropriately, so the virus is not able to continue to replicate and infect other cells. Fusion inhibitors act to prevent the HIV from entering the CD4 cells. This particular agent is almost never used. It was a complicated injectable regimen that generally is not well tolerated. Entry inhibitors, there's currently only one in this particular class right now. It blocks another receptor on the CD4 cells to prevent HIV from getting in. Integrase inhibitors have really changed the face of HIV therapy. They block the HIV virus from integrating into the host cell DNA. These are very, very effective medications, extremely well tolerated, very few drug interactions. And as we get into the guidelines, you'll see that this has really been reflected in how we treat HIV. As I mentioned, there's this thing called a pharmacokinetic enhancer. There are 2 agents that do this. One is ritonavir, which is an older protease inhibitor that's only used for this function, and a newer one called Cobicistat, which we'll talk about in a little bit. What they do is they block the metabolism of certain other agents, leading to higher levels of that other drug. So you get an enhanced level of that drug to make it more effective. And then there are multiple combination agents. Some contain only 2, some contain 3, some contain 4, and there are 6 that are fully complete regimens in one single tablet. So the guidelines that have just been updated this October really focus on the integrase inhibitor-based regimens. There used to be some other options considered as your first choice. Right now, the top 4 all contain an integrase inhibitor, and these are recommended for most people with HIV. They do make an exception, which I'll get to in the next slide, that some options may be better for other individuals, but all things being equal, you want to start with an integrase inhibitor-based regimen because they're so effective, so well tolerated, and so few drug interactions. So one of the recommendations is Dolutegravir combined with abacavir and 3-TC, so that's an integrase inhibitor, 2 NRTIs. Abacavir is a particular drug that is linked to allergic reactions in individuals who have a certain HLA subtype, this HLA B5701. So that always has to be tested before you consider using abacavir for anybody. Another option is Dolutegravir, not in a single tablet regimen, which the one above is, but combined either with TDF and FTC or TAF and FTC, and we'll talk about what those differences are shortly. Another single tablet regimen is Raltegravir combined with Cobicistat, that's a pharmacokinetic enhancer, plus FTC and TAF, or potentially TDF, and we'll talk about that again in a few slides. And the other option is Raltegravir, either as a once-a-day dose or a twice-a-day dose combined with TDF, FTC, or TAF, FTC. The other options that can be considered include some of the older agents like protease inhibitors, either boosted with ritonavir, as I mentioned before, or Cobicistat. The advantage to combining with Cobicistat is that now it's combined into a single tablet, so there's fewer drugs. Again, combined with either tenofovir, FTC, either TAF or TDF. The other option for protease inhibitors is something called atazanavir, combined with Cobicistat or ritonavir. Other options combining with another NRTI combination. NNRTIs plus 2 NRTIs. One is efavirenz combined with a tenofovir compound plus FTC. Efavirenz plus TDF FTC was the first single tablet regimen available. This is an option for some individuals. It's an older drug. Efavirenz has quite a few CNS side effects, can cause some changes in sleep-wake cycle, some anxiety, some very vivid dreams. So this is fallen out of favor for a lot of individuals, both providers and patients. Rilpivirine plus tenofovir FTC comes in a single tablet regimen as well. Restrictions on this is it cannot be used if a person has a higher viral load. So the viral load has to be less than 100,000 and CD4 count has to be greater than 200 cells. In addition, rilpivirine has some restrictions on use with proton pump inhibitors and has to be given with a full meal. So there are a few restrictions with that particular agent. Other options are an integrase inhibitor, Raltegravir, given with abacavir 3-TC as opposed to the tenofovir combinations. And then a few options if you want to have what we call a nuke-sparing regimen, so avoiding the NRTIs for whatever reason, either due to prior resistance or transmitted resistance, side effects, things like that. There are certain circumstances where you want to avoid the NRTIs. So Darunavir plus ritonavir plus Raltegravir has been studied, only Raltegravir given twice a day, and this should only be given again with a lower viral load and a higher CD4 count. Or lopinavir ritonavir, which is an older agent that we really don't use very much anymore, but it is a fixed drug combination, plus 3TC. These have been studied. They're not used very frequently in these combinations, but they do at least provide some alternative for certain individuals. The IAS guidelines have not been updated yet this year from 2016. They're very, very similar to the current DHHS guidelines. Although you'll notice here, they make it even simpler. They've gotten the older version of tenofovir, the TDF, which we'll get into again in a few slides. They've gotten that off the list, and they only focus on the newer formulation, which is TasP. When we choose a new regimen, there's either initiation of first treatment, so the patient is treatment naive, they're about to start on their first therapy, or you're switching. When we switch, it could be for a couple of different reasons, but this is somebody who's already on therapy and there's some desire to change. The factors that influence your choice for a naive patient can be pill burden, how frequently the dosing is given, once a day versus twice a day. The size of the pills can be an issue for certain individuals. How compliant you expect that patient to be. When we're worried about patient compliance, that they may miss, quite a few doses, we often talk about using an agent that has a higher barrier to resistance, so it's more difficult to develop resistance to that regimen. You have to look carefully at any drug-drug interactions that other medications they might be on. What are some of the side effects? What are some of the potential long-term toxicities? Are there food requirements for some individuals? Eating a specific meal each at the same time every day can be challenging, and that's a requirement for certain of the agents. Is there any baseline resistance? Patients do get resistance transmitted from other individuals on occasion, about 15 to 20%. If they're pregnant or planning on potentially becoming pregnant, you want to choose a regimen that has a better track record in pregnancy. As I said, there's certain restrictions based on CD4 count or viral load at baseline. Do they have any allergies, in particular the HLA B5701 status, co-infections, as I mentioned before, and comorbidities? As we mentioned, there are some additional specific items that you think about when you're coming up with an initial regimen. We've touched on most of these before. I won't go into this in great detail, but again, there are certain restrictions if the CD4 counts are less than 200, if the viral load is greater than 100,000, if they're HLA B5701 positive. And then the other thing that is playing a little bit more of a role is the concept of test and treat, which is an area of active research. There's been a few studies that have come out supporting this idea that if you diagnose somebody and then you immediately get them on treatment, you may have better long-term outcomes, may be able to retain them in care longer, get that viral load to undetectable more quickly. It doesn't work in every situation. You have to have a full team to support an individual who gets that new diagnosis of HIV to get them onto treatment right away. But there are a couple of options that you may want to turn towards if you're going to do test and treat, because you will not have your genotype information yet. You won't know if the individual might have some underlying resistance. So you want to choose a regimen that has that higher barrier to resistance. They're less likely to break through, even if there's a little bit of resistance. So using a protease inhibitor, darunavir, either boosted with ritonavir or Cobicistat, plus a tenofovir containing compound, or Dolutegravir, which is an integrase inhibitor with what we think is a higher barrier to resistance, again, combined with tenofovir FTC. So that's a unique situation, but something that also has to be considered. Why would you switch a regimen? Of course, if the regimen is failing, a person is having a breakthrough of their virus and they're developed resistance, you need to choose a new regimen to get them to be undetectable. One of the big pushes these days is simplification. Some patients have been on more complex regimens for a long period of time because that's what was available when they first started treatment 5, 10, 15 years ago. If there's not a lot of other issues going on, there's not a lot of other underlying resistance, you can simplify the regimen. Get them from a twice-a-day regimen to a one tablet once a day. Really can improve their overall lifestyle. They get less pill fatigue, so that's something else that we consider. If a person has side effects, maybe they sort of tolerated their side effects for a really long time because they didn't have a lot of other choices. Now with new choices available, you may be able to mitigate some of those. Minimize long-term toxicity. This is usually a doctor-motivated change. So looking at the regimen they're on, thinking about some of the long-term consequences, switching them to a regimen with perhaps lower risk of some of those toxicities. Patients going on new medications. Maybe now that they're in their 50s, now their cholesterol is elevated, they need to go on a statin. You may need to adjust their HIV regimen so they can safely be on that. Perhaps they're going on Hep C treatment. Sometimes you need to make adjustments in order to be able to give those new meds. And then again, as I said, any new comorbidities may affect your HIV regimen. So now moving on to where we have developed over the last couple of years with some of the newer agents that have come out and some of the newer agents that should be available really probably within 2018 and beyond. So before I get into that, I do have a question for the audience. Which of the following is the primary difference between TDF and TAF? I've alluded to there being some differences. There's all these choices. What are the differences? TDF is associated with lower renal and bone toxicity than TAF. TAF is associated with lower renal toxicity but higher bone toxicity than TDF. TAF is associated with lower renal and bone toxicity than TDF. TAF, but not TDF, is licensed for PrEP. I'll give you a moment to answer. Okay, so the answer is that TAF is associated with lower renal and bone toxicity than TDF, and I'm going to get into this in the next few slides. So 2015 to 2016 were really quite busy. There were quite a few new compounds that came out, and I'll break them down by category as I see it. So there were several new Cobicistat containing compounds. As I mentioned before, Cobicistat is a pharmacokinetic enhancer that increases the levels of the drugs that it's combined with. So there's atazanavir Cobi, darunavir Cobi. So these are single tablet containing these two drugs, simplifying things a little bit, and then a full single tablet regimen of FTC, TAF, Raltegravir, which is an integrase inhibitor, plus Cobicistat, and these all came out in 2015. And then there's the TAF containing compounds, FTC, TAF, Raltegravir, Cobi, which I just mentioned, FTC, TAF, Raltegravir, and these two regimens, the Raltegravir and the Raltegravir regimens, replaced earlier versions of these combination single tablet regimens, which contained TDF instead of TAF. So it was just a slight switch. And then FTC TAF just on its own, that came out in April 2016. And then one that just came out within the last few months was a single dose Raltegravir given once a day. Sorry, not single dose, Raltegravir given once a day, 2 tablets at a higher dose. So TAF. This is a big change over the last couple of years, and it's a very interesting idea how they came up with this new medication. So tenofovir is the actual active compound. Tenofovir can't be given on its own. It has to be given as a prodrug. And the original prodrug was tenofovir disoproxil fumarate, much easier to say by TDF. And this has been used for a very long period of time. Very effective medication, generally well tolerated by individuals, not a lot of side effects of an individual experience, but there have been some long-term toxicity issues associated with TDF. Renal toxicity and bone toxicity in particular. Patients with renal toxicity can end up having a Fanconi's-like syndrome. They can lose potassium and phosphorus, can occasionally progress to significant renal failure. And the bone toxicity can lead to decreased bone mineral density to really pretty remarkable levels and potentially leading to increased risk for fractures. The newer version of TDF is TAF, tenofovir alafenamide, also easier to say by just TAF. And the big difference is how it's metabolized. So whereas TDF gets converted into the active drug, tenofovir, in the plasma, where you have a lot of that active agent floating around, can get to multiple cells, can get into the renal cells, can get into the bones, can get into other sites, TAF is mostly converted to the active agent within the cells themselves, within the lymphocytes where you really want it to treat the HIV. So very, very significantly lower levels of tenofovir in the bloodstream, in the plasma. So you see less of those toxic side effects. Less renal toxicity, less bone toxicity. The one potential advantage to the older version of the TDF is that it was associated with lower lipid levels. We've seen this compared to some of the other NRTIs as well. What this means in terms of clinical significance is really unclear. Whether that lipid lowering really is cardioprotective hasn't really been shown to be the case, but it is something to be aware of if patients are changing from TAF to TDF potentially, or from TDF to TAF. The TAF, as I mentioned, is available in 3 different co-formulations: the integrase inhibitor, Raltegravir, Cobi, the Raltegravir, which is the NNRTI, and then just with FTC combined. TAF is also marketed as Zemliti specifically for Hep B treatment, just like TDF can be used for hepatitis B treatment. Per the IAAS guidelines, they have, as I showed you before, completely taken TDF off the list, so they only recommend FTC TAF compounds. The DHHS recommends combinations with tenofovir, and then says that you can use either TAF compounds or TDF compounds. That's where they currently stand at this time. Another significant difference between TAF FTC and TDF FTC is that TAF has not been studied specifically for treatment for PrEP, so pre-exposure prophylaxis. There is a very, very large study going on right now looking into this. It's not clear that TAF gets the same levels of drug in the areas you're concerned about, so the vaginal mucosa, the rectal mucosa, et cetera. So it's going to take a few more years to get that data back, whether TAF will be a substitute for TDF for PrEP. So that remains to be seen. Another restriction is the TAF can't be used in creatinine clearance less than 30. The cutoff for TDF is less than 60. And there's limited data on TAF in pregnancy. It just hasn't been studied yet. The phase 3 trials looking at Raltegravir, Cobicistat, TDF-FTC versus the TAF-containing compound, it's gone out to 144 weeks, and has shown that TAF-FTC was superior to TDF-FTC, achieved viral loads of less than 50 copies, mostly due to a higher rate of discontinuation in the TDF arm, and this was likely due to renal toxicities more than anything else. At 144 weeks, participants in the TAF arm had significantly smaller reductions in their bone mineral density at their spine and hips than those in the TDF arm, so it really has been shown to have a significant difference. And through 96 weeks, the change from baseline estimated GFR and renal tubular function and discontinuation for renal adverse effects favored the TAF arm. Also at 96 weeks, they did show this fasting lipid levels, including LDL, HDL, and triglycerides, did increase slightly more in the TAF arm than TDF arm. No change in total cholesterol to HDL ratio, and the clinical significance, as I said, remains unclear. A phase 2 trial of Dorunovir, Cobicistat, TDF-FTC versus Dorunovir, Cobicistat, TDF-FTC. This has not been marketed yet, but it's, we'll talk about it in a few slides, showed very similar virologic suppression rates in each arm, and again, showed benefit in terms of the kidneys and bones, less proteinuria, and less change in the BMD observed in the TAF arm. As I mentioned, there's the Cobicistat compound. It mostly simplifies administration, so atazanavir Cobi and Dorunovir Cobi are both single agents as opposed to giving atazanavir plus a second ritonavir pill. No data in pregnancy for either of these combinations with Cobicistat, and the reason that's significant is as you advance in pregnancy, the volume of distribution and the way you metabolize drugs does change. We have a fair amount of information of how to dose atazanavir and Dorunovir combined with ritonavir in those later trimesters. We simply don't have that information in Cobi, so would not recommend it in those situations for those individuals. Cobi is also marketed on its own as TasP is the name. It's a single tablet. I haven't seen it used very much on its own. Its main function is being given in combination. But interestingly, although it boosts, just like ritonavir, Cobi only inhibits the CYP3A4, whereas ritonavir inhibits several P450 enzymes. So there are some more drug interactions with ritonavir than Cobi, but you still need to look very, very carefully whenever you're giving Cobi to a person on other medications because it still can interact. So still need attention to that. Another feature of Cobicistat is that it inhibits tubular secretion of creatinine, leading to an increase in serum GFR and increase in serum creatinine and a decreased GFR, but it doesn't really affect renal function. It's very similar to what happens when somebody's given Bactrim. And usually this bump in creatinine hits up to about 0.14 over the several weeks of being on the med, and then it stabilizes. If you have a patient on one of these Cobi-containing regimens and you see the creatinine continue to climb, it's something other than Cobicistat causing it, but it's something to be aware of. So the other new regimen that I mentioned was Raltegravir HD. So this is a drug that's been around for a long time. It was the first integrase inhibitor that came out. Its biggest disadvantage is that it's a twice-a-day drug, 400 milligrams twice a day, and so the company designed a newer option to give it once a day. When they previously looked into giving the two 400 milligrams once a day, they had a significant number of failures. Changing it to two 600 milligram tablets once a day did have good outcomes. It is still 2 tablets as opposed to a lot of our other options, which are 1 tablet. And by giving it once a day, some of the drug interactions have changed a little bit. So it cannot be given with calcium carbonate antacids, rifampin or etravirine. It should not be given with the once-a-day dosing of the Raltegravir. It should not be administered with calcium carbonate, rifampin, or etravirine, whereas with the BID dosing, those drugs could be given in combination. So people have to be just a little bit more careful about that. And the HD dosing has not been studied in pregnancy, whereas whereas the BID dosing has been studied extensively in pregnancy and is one of the safer options that we can give. Some of the new agents that are going to have either already been submitted to the FDA or will be in the very near future. Dorunovir, Cobicistat, FTC, TAF, which is a single tablet regimen. A new integrase inhibitor, Bictegravir plus FTC and TAF. And Dolutegravir, Rilpivirine, which is a 2-drug single tablet regimen. Dorunovir Cobi FTC TAF will be the first protease inhibitor-based STR, which is a really nice option, especially for people who have more drug resistance because the protease inhibitors have that high barrier to resistance. May be a nice option for test and treat if you do not have that genotype available, since I do recommend Dorunovir, boosted Dorunovir plus tenofovir FTC was one of the listed options. This would be a much simpler version of it, just 1 pill. Other than that, the drugs are all familiar drugs, nothing else new about that regimen. Bictegravir FTC TAF is a new highly potent integrase strand transfer inhibitor. Integrase inhibitor is how we usually refer to them. It's given without boosting, which is a big change compared to the other integrase inhibitor that's combined with FTC TAF, the Raltegravir, which has that Cobicistat booster in it. So it's nice that you do not need to worry about those drug-drug interactions in the same way. It's non-inferior when it was compared in studies to Dolutegravir, Abacavir 3-TC, which is also marketed as a single tablet regimen, also non-inferior to Dolutegravir plus FTC TAF. So Dolutegravir is the currently available integrase inhibitor with what we think is the highest barrier to resistance, generally well tolerated. It's a really excellent agent for a lot of people. This compared very, very favorably to it, and offers a new single tablet regimen without that boosting and combined with FTC TAF. It also seems to have an even higher barrier to resistance. It's active against most integrase inhibitor resistant variants. It has a very long dissociation constant from the HIV virus, which again suggests this high barrier to resistance. It's really hard for the drug to separate from the HIV virus, which makes it more difficult to develop that resistance. It's also metabolized, interestingly, by both CYP3A4 and UGT1A4. So there's few drug interactions because you really have to interact very, very strongly with one of those other enzymes to cause significant drug-drug interactions. So has some advantages potentially. And then Dolutegravir Rilpivirine is kind of a paradigm switch for a lot of us. It's a 2-drug STR. All the other STRs are 3 to 4 drugs, including a pharmacokinetic enhancer in certain ones. And the idea is that maybe for some individuals, you want to have that nuke-sparing regimen, so not including some of those standard drugs that we use, TAF, FTC, Abacavir, TDF, et cetera. It's an integrase inhibitor that we're very familiar with, Dolutegravir, plus an NNRTI, which we're also quite familiar with, Rilpivirine. They looked at studies switching from a suppressive 3-drug regimen to Dolutegravir Rilpivirine with excellent results in terms of maintaining viral suppression. So patients who were undetectable changed to this new option, still did extremely well. But it's not considered yet as a drug for naive individuals. This is only for switching, only for simplification for people where you want to potentially get rid of those nukes. It's not an option for naives. The only major disadvantages that persist with this combination are that there still are the same food restrictions and proton pump inhibitor restrictions because of the Rilpivirine compound. So Rilpivirine has to be given with a 400-calorie meal, and it has to be a meal. It can't just be a protein bar. 400-calorie meal in order for it to be absorbed appropriately, and it can't be taken with a PPI. So those restrictions will still apply for this combo regimen. It has a neutral effect on lipids, which is a nice advantage. So there may be a subset of people where this would be a nice option for them. And some of the new things that we're anticipating, these are familiar classes, just new versions of them in phase 3 development. So Doravirine is an NNRTI. Cabotegravir is an integrase that has both oral and intramuscular formulations, known as CAB-LA, long-acting. Cabotegravir Rilpivirine LA co-formulation given IM, and lamivudine combined with Dolutegravir. The Doravirine is a once-daily NNRTI that has a high barrier to resistance and retains activity against first-generation NNRTI mutations. It's being developed as a single-tablet regimen with, interestingly, TDF and 3-TC. So the main motivation for that is, as I understand it, is due to TDF and 3-TC becoming generic. So using that for cost issues, it's interesting because most of the other regimens contain TAF as opposed to TDF, so it'll be interesting to see how that goes. It's been shown to be non-inferior to Darunavir, Ritonavir, and Ephedrine's TDF FTC-based regimens in naive patients. It seems to be very effective. No major side effects so far. So it's nice to have another agent in that class, particularly for people who have resistance. What role it's really going to play compared to some of the agents, it's not clear yet. One of the more exciting ones that's being developed is Cabotegravir, which is, again, an integrase inhibitor that has both a PO and an IM formulation. The CAB-LA, the IM form, has a very, very long half-life, and they actually can detect levels of the drug up to a year after dosing. You need to do an oral lead-in phase before you can do the injectable version because you need to screen for adverse effects. So you don't want to give a patient a med that they're basically going to be on for a year and then find out they have side effects. So you always have to do this lead-in period. It has a very similar resistance profile to Dolutegravir, which is a good profile. It's been studied in combination with long-acting injectable Rilpivirine for naive patients with very high rates of virologic response and good tolerability. They're currently looking at either giving it Q4 weeks or Q8 weeks. There were a few more virologic breakthroughs in the Q8 week study, but they haven't completely ruled that out as an option. So continuing to be developed. One of the other areas where CAB-LA may really have a role is in PrEP, so the pre-exposure prophylaxis. And currently the only option for PrEP is TDF-FTC, and it is quite effective. This is a different approach, which is the drug is given every 8 weeks. They've shown that for PrEP, the every 8 weeks seems to work fine after you do that 4-week oral loading dose. So for some individuals, maybe a nice option. They only have to come in to see the doc every 8 weeks to get their PrEP dose. Again, for patients who would be treated with the combination Cabotegravir and Rilpivirine, It's either every 4 weeks, maybe every 8 weeks. It is a large volume to be injected. So again, I think once it gets closer to being licensed, the role may be, you may have to find a specific individual where it's really appropriate for them. So more remains to be seen, but it is an exciting new approach to treatment and prevention. The last new agent in phase 3 development is Dolutegravir and 3TC. It's a single tablet regimen, and it's been studied both in switch and in naive. So in patients on a fully suppressive regimen, switched to Dolutegravir and 3TC, there was no significant virologic breakthrough, so it worked pretty well. And there was a pilot study, so a very small number of patients so far, and it showed efficacy in naive patients with lower viral loads, less than 500,000, that it did seem to be effective. So it might be an option for patients who can't take NRTIs due to tolerability or resistance issues. I think it's a challenging concept for a lot of us because 3TC is not a very potent agent all on its own. So we're giving a very potent regimen with a Dolutegravir arm with just one other medication combined. Again, I think we need more data on it to sort of see where it's really going to go. But a lot of new approaches to HIV management. And then some of the newer agents in totally different classes that are in phase 3 right now, still a long way from being submitted, but really interesting. There's Imbalizumab, which is a monoclonal antibody. It blocks HIV entry, so different from the older HIV entry inhibitor that we have. It attaches to the CD4 receptors and stops the changes that have to occur to allow the virus to enter the cell. It's active against both CCR5 and CXCR4 tropic viruses, which is interesting because the other CCR5 receptor blocker obviously only blocks CCR5. Has a very long half-life. It does have to be given by infusion. Right now it looks like every 2 weeks. And this is really only for people who are highly treatment experienced with extensive resistance. And although we do not see as many people failing these days as we used to, there are definitely still a population of patients who have very advanced disease with a lot of resistance mutations and need other options if they've already kind of burned through the other options we have available. So this is very exciting. It's a very new approach, and I think maybe a good option for some of our more complicated patients. And there's Pro-140, which is an IgG4 antibody that blocks HIV entry by binding to the CCR5 receptor. So acts differently than the current CCR5 receptor blocker. It is active against a virus that has become resistant to Moravirine, which is another CCR5 receptor blocker. So again, a new class of drugs, a new option. This would be weekly subcutaneous injections. So as you can see, there's a real shift. We're trying to get away from oral agents and shifting to parenteral methods. So there's a lot more that are still in early phase development. HIV continues to be an area of active research and active development. So the takeaways from I know a lot of information. One of the keys is that we are still seeing HIV infections. They are particularly in young MSM of color being disproportionately affected. So it is an ongoing problem. This is not something that we can become lackadaisical about addressing. The guidelines recommend that all HIV positive individuals start antiviral therapy regardless of CD4 counts. The guidelines clearly emphasize treatment regimens that include an integrase transfer inhibitor and focus on simplicity, tolerability, and efficacy. Products approved over the last 2 years include 2 single tablet regimens, new versions of familiar agents to improve pill burden and dosing frequency, as well as several compounds that include TasP, which is the new prodrug of tenofovir with an improved safety profile compared to TDF. New agents likely to be approved in the next 2 months include 3 single tablet regimens that are expected to be well tolerated and efficacious. At this point, I will now turn the presentation back over to Dr. Kenny. Thank you very much for your attention.
Thank you, Dr. Kogelman. I will now discuss incorporating new therapies into formulary, what to know in advance of new guidelines. I'm going to start with a polling question. How does the cost of HIV medications compare to costs for other specialty products? A, HIV medications cost less than other specialty products. B, HIV medications cost roughly the same as other specialty products. Or C, HIV medications cost more than other specialty products. So what are the management challenges of complex specialty drugs? Certainly, we want to ensure clinically appropriate use of these agents. We want to determine the value of the specialty drugs that are being used and prescribed by our providers in our network. We want to manage oncology drugs and services as a standard requirement, if you will. Responding to the drug pipeline, coordinating across both the pharmacy and the medical benefits, which can be particularly challenging for health plans because you need to make sure that your procedures and policies align across the different benefits. Managing site of service for infusions, obtaining buy-in for any utilization management from patients and providers, and certainly any successful utilization management program needs to have that level of buy-in. And lastly, improving adherence and persistency for patients on specialty drugs. And this is data taken from the EMD Serono Specialty Digest, which was published in 2017. Plans continue to rate dispensing and patient services as the most valuable services that are provided and received from a specialty pharmacy. And this is additional data from the Serono Digest. And what we see here is specifically that dispensing is well above the 80% level in terms of importance and value, but also it is a common service that's received directly from the specialty pharmacy. Certainly patient services and reporting also are near the top of this scale, if you will, as items that are very important and critical for health plans as they try to manage this complex disease space of specialty, which of course includes the HIV medications. Some key initiatives viewed by health plans to manage specialty drugs, certainly new and enhanced utilization management techniques, and this may involve electronic prior authorizations or electronic step edits to try to improve that process and turnaround for providers. Increased use of these prior authorizations more broadly, so not just for a small handful of medications, but we see more and more drugs that are coming to market in the specialty space are seeing some prior authorizations put in place. And our objective here clearly is to promote appropriate use. It's not focused on denying access to products or preventing physicians and patients from having appropriate access, but we want to make sure that the population of patients that goes on these drugs is the right patient group. Targeted benefit changes certainly is another aspect of this layer of new initiatives we're rolling out. That includes the changes to the Pharmacy and Therapeutics Committee, new clinical programming, standard formulary changes. We're seeing increased levels of cost sharing among the patients, and we have to balance that with the needs of the patient and the risk of the patient abandoning those prescriptions. And clinical pathway programs. So these are all targeted things within the benefit that we're changing to both manage utilization appropriately, control spend, but also hopefully improve outcome in the patients who are treated with these drugs. Site of care changes is another opportunity for us as we try to move patients from perhaps the inpatient hospital or outpatient setting over to the home or home infusion, or even in the home where the patient could self-administer some of these products or have a caregiver deliver those in the home. Specialty pharmacies do improve adherence to medications. This is data from a number of studies that shows that the pharmacist medication therapy management programs do in fact improve compliance with HIV medication. And it's been demonstrated both at the retail and specialty pharmacy level. And in these studies, it demonstrated improved adherence, better outcomes, and particularly HIV, reduced viral loads, and improved CD4 T lymphocyte counts. So again, documented proof that improved adherence programming through these pharmacy channels does lead to improved outcome. Specialty pharmacy services that are directed to the HIV patients, clinical interventions, psychosocial assessment, as well as integrated nursing staff capabilities that may be generated directly from the specialty pharmacy, or it may be part of a health plan's case management team or case management service that does get offered to a patient. Prescription fulfillment, obviously we want to have the drug in stock if the patient needs it, and with large quantities of drug being dispensed by these pharmacies, it's unlikely they would be out of stock and the patient is not going to run into a situation where they go off the medication, where there is risk, obviously, for resistance to develop if a patient doesn't maintain a daily dose of that drug to minimize the viral load of the disease. Compliance and adherence programming certainly is important, as well as support for the AIDS Drug Assistance Programming, or ADAP, can be provided by specialty, as well as a number of other financial assistance opportunities, whether it's manufacturer copay assistance, generic patient assistance programs, or PAP, through foundations and the like, and general educational services, and access to clinical staff as well for counseling on disease and drug interaction conversations to make sure that the patient is getting the best value out of their medication therapy. HIV therapies in general, there are multiple combination regimens recommended by DHHS. The average cost per month of these combination treatments ranges from $1,500 to $4,000, so clearly a price that falls into that category of specialty drug that plans are concerned about. The cost of the products is in fact in line with typical specialty products, as we saw in the polling question. Some plans require specialty distribution for HIV medications, and we can target these for split dose programming, although in HIV it may not be as attractive an option as we have seen in some of the oncology space, because most of these newer regimens and combination therapies are well tolerated. And generally, a split dose regimen is going to focus on tolerability concerns with a product that can be quite expensive. Concerns about advocacy resistance to utilization management programs is also a factor that needs to be considered. And limited use of utilization management by plans due to similar prices and often individualized approach to treatment is one of the reasons we don't see as much aggressive utilization management in the HIV space. If we look at the Express Scripts Drug Trend Report for 2016, looking at the top therapeutic classes by spend, we can see here that HIV came in the 6th position with a per member per year expense of $39.92 and a trend actually of 21.7. And the biggest portion of that trend in 2016 was a cost trend, about 16.2%, with utilization being 5.5% of that trend. So if we dig a little deeper into the HIV drug trend for 2016, again, number 6 overall with these trend numbers and the dollar spend, it was the number 1 class for Medicaid with 7 out of the top 10 specialty drugs. It was the number 1 class for health exchange populations with 5 out of the 10 specialty medications in the HIV space. Trend is expected to be about 20% for the next 3 years, and we do have emtricitabine, tenofovir, disoproxil fumarate was a top 10 specialty drug in 2017. This is a drug used for PrEP, or pre-exposure prophylaxis, and that had a trend of 37.8%. So that was clearly a key driver of that overall trend in 2016. The average cost per month of therapy in this category, about $1,500. And the top five products by market share you can see listed here. Again, a number of different products generating the total class positioning of number 6 on the overall specialty drug trend. If we look at the pipeline, we've got 52 products in the development pipeline. 32 of these are antiretrovirals or antivirals, 16 are vaccines, and 4 are cell-based therapies. So again, some different mechanisms potentially at play here and different options to treat this population are coming. Here's a picture of the overall pipeline, taking us from 2014 to 2020, and you can see here a number of different products clearly that are available. Above the line, we have generics, and below the line, we have the novel pipeline, which is the one that we pay most attention to as a health plan. Some of the challenges to managing HIV medications on formulary certainly include things like when to start treatment, selection of an appropriate regimen, difficulty in managing choices for physicians and patients due to the fact that the regimens are indeed individualized, evaluating the opportunity to prefer medications, and promoting switching to more cost-effective products is certainly a challenge. Compliance with guidelines, strong efficacy for multiple recommended regimens per DHHS guidelines makes the issue of managing them somewhat more difficult, and really a desire to pursue outcome contracts in the HIV space is something that exists but has not really come to fruition to date. So guidelines focus ideally on when to start, and we can see here a number of guidelines, and what's comforting in the HIV space is the fact that they're all pretty current. So these are all guidelines within the last 2 years, and in the case of the DHHS guidelines, they were updated in October of 2017. So very current guidelines that are available to follow. The recommended regimens are in line with that, and we see here they all are driven primarily by the use of an integrase inhibitor, and Dr. Kogelman did an excellent job of presenting these drugs and the appropriate regimens to treat naive patients. The benefits and challenges of early therapy, also referred to by Dr. Kogelman, certainly reduction in death, AIDS-related illnesses, some of the non-AIDS specific conditions. Starting therapy when patients are younger generally yields better CD4 cell improvement, preserving the immunologic function and enhanced recovery to CD4 count, and reduction clearly in the risk of HIV transmission. Challenges here in the benefits, the impact of adverse effects on quality of life and adherence, the impact of non-adherence on efficacy, resistance, costs associated with therapy, and financial and workforce resources, and indeed the need for broader testing. So there are certainly benefits and challenges of early therapy. Regimen switching, when and how. Certainly the IAS USA guidelines, again, also current 2016. Switching can be due to adverse effects, simplification, drug-drug interactions, pregnancy or planned pregnancy, and food restrictions. It's not recommended to do induction maintenance strategies, switching from 3 to 2 drug regimens. And the role of resistance testing also is something that needs to be configured and managed by the health plan to effectively manage the patient population on HIV therapy. Outcomes-based contracting is used by a small minority of plans, but there is a lot of interest here, and certainly the HIV space could be one where an outcomes-based contract could provide value both to the plan and improve the positioning of a drug on the formulary. Some key takeaways: select categories have not been aggressively managed, including hemophilia, HIV, and oncology historically by health plans, and that is changing due to generics and the overall cost and pressure to control spend in the specialty space. Adherence is clearly continuing to be a critical challenge in this space. Outcome contracts do present a viable option to bend the cost curve. Coordination of care always offers value in the HIV space, whether it's case management, disease management, or medication management. And certainly multiple stakeholders are required to achieve success as we manage these patients, including providers, patients, health plans, and pharmacies. This concludes my portion of the presentation. Dr. Kogelman, please provide us with any final thoughts you'd like to share today.
Thank you, Dr. Kenny. With the new drugs that are coming to market, cost containment will continue to be an issue that needs to be addressed, as I think has been clear. However, many of the agents that have been developed or are in development offer improved safety profiles which will benefit patients over the long term. The favorable safety profile of TAF-FTC in particular has been reflected in the evolving IAS and DHHS guidelines, and there's been a strong emphasis on single tablet regimens or at least once daily dosing that has also been reflected in the guidelines. New agents likely to be approved in 2018 are all single tablet regimens that appear to be highly efficacious with limited toxicity. And starting and keeping patients on these highly efficacious, well-tolerated regimens with minimal toxicity is really critical to long-term compliance, which ultimately benefits the long-term health of people living with HIV who can now expect and close to normal life expectancy. Thank you very much.
Thank you very much for attending this webinar. We will now open up the question and answer session. Good afternoon, and thank you for joining us for today's webinar. My name is Jim Kenny, and I will be your moderator for today's question and answer session. My colleague, Dr. Warcel, will be answering questions with me today. As a reminder, if you would like to ask a question, please type your question into the question box on the screen. Our first question: do you think breaking medications into their component generic tablets or generic elements is a good option? We'll pose that to Dr. Warcel.
I think, you know, in the United States, at least, we're sort of a resource-rich setting, and when you break the tablets into their generic counterparts, there's a lot of potential problems that can happen. There's often increased pill burden and mistakes that can happen with appropriate dosing of the questions. So I'm someone who favors not doing that. What it can be useful for sometimes is if you have people who have difficulties with insurance, or in some states where the insurance coverage is not as great as we're lucky to have in Massachusetts, it may be your only option. But when you're doing that, there has to be lots of discussions and reinforcements on the correct way to take the pills, because it poses risks for adherence and it poses risks for medication errors.
Thank you, Dr. Warcel. And I'll just comment from the health plan perspective. We certainly agree our formulary committee is generalist, but we also have HIV specialists that do participate in the process. But I think the challenge we face, of course, is the cost of these therapies. And if we had an option to split perhaps a multi-drug regimen into a couple of its components, there would have to be a reasonable amount of savings potential. I mean, if it was literally, $5,000, $6,000, $10,000 in savings per year per patient, it might be a consideration. Obviously, for some patients that have a challenge of dealing with a split regimen or more prescriptions, not necessarily ideal, but with the pressures we're under to control costs, certainly sometimes plans would consider something like that. Okay, our next question. Go ahead, please.
Sorry, it's a tough question, and I think the risks and benefits have to be weighed, and I think that the costs of not treating HIV, meaning someone only taking their pills once a day or incorrectly, could potentially lead down the road to worse an HIV infection, more hospitalizations. But I do appreciate the pressure that you're under, and if there are significant cost savings, I think a lot of cost effectiveness studies would show that just getting HIV medicines into the person is the most important part of the equation.
Yeah, and I don't disagree, and certainly our formulary committee is fully supportive of that. It would have to be a significant difference. And again, we've never done that. I know there are some plans in the country that have chosen that method, but I would certainly agree. Our next question from the audience: what would you recommend for patients who cannot swallow pills?
I guess in that situation, it could either be that they cannot swallow pills because of restrictions in swallowing, meaning that they've had a stroke or they have like true dysphagia problems, or that they just are someone who's not a pill swallower. So I'll approach those as two different things. I think if you just can't swallow pills and that crushing the pills is an option, I think there are pills that you can crush, and that I would just check with your local pharmacist about that and which pills are crushable. If they cannot swallow pills in that they have a restriction because of a stroke or they're an aspiration risk, I think that's probably an indication for a G-tube. I'm guessing those patients would already have that for nutrition needs. So those are the two ways that I come at that question. But if there are any other thoughts that the person had in mind with that question, happy to discuss that more.
Yeah, from the health plan perspective, we're certainly going to cover whatever's necessary. If you have a patient who can't swallow or has aphasia or whatever it might be, whatever's necessary is certainly going to be covered without any undue restriction. Makes perfect sense. Next question. Do you think the more recently approved medications offer a significant advantage over earlier regimens?
I do think that the new ones offer a very big advantage, especially the Dolutegravir and the newest integrase inhibitor, which is going to come out, which is Bictegravir. They have a durability that we see time and time again with people who are unable to take or forget sometimes their pills despite all of our counseling. They're more forgiving. And I think from the lipid profile and the metabolic syndrome profile, they're nicer on the body. Definitely the TAF medications are better for renal and bone health. So absolutely, my first choice is always to try to get a patient on a Dolutegravir-containing regimen. I do think it is the best for our patients.
So it sounds like then the new dual combination, so a two-drug combination with Dolutegravir that just got approved is going to be an attractive product. And one of the questions here relates to what about moving from a 3-drug regimen to a two-drug regimen? Is there a concern regarding potential for resistance, or is Dolutegravir such a good backbone that you don't need to worry about that?
Well, I'm not a big fan of the Dolutegravir-Rilpivirine combination. Overall, Rilpivirine has a lot of different restrictions on when you can take it, and given how common proton pump inhibitors are and antacids, I avoid Rilpivirine. So I think there's a lot of things about the new Dolutegravir-Rilpivirine combination that even though it can be used, it's not going to be my first go-to. And as far as the 2-drug combinations go, I believe in it, but I'm not going to start doing it until I see more data, unless I'm forced. I do have people on some people on 2 pills, but it's usually Prescobix, which is boosted Doravirine in addition to Dolutegravir, and that's only in the setting of them having resistance to NRTIs and NRTIs. So I think I'm not convinced overall that less medicines is more, especially since we have so many medications that could be co-formulated into one tablet. Again, in resource-limited settings, that may change. So that may be different, and depending on the restrictions of the healthcare plan, that moving forward, the formularies may change. But at this point, I'm still going to try to use 3 medications at all times.
Great, thank you very much. The last question. From a patient perspective, what do you think are the most important features of an HIV regimen? I
think once a day is what everyone wants. It's what everyone asks for. I see a lot of people, I start them on a lot of HIV meds, and if there's a way to incorporate medications and make this diagnosis fold into their lives, that's the most important part. The second question that always comes up is side effects. And so things like protease inhibitors or medications that contain Norvir sometimes cause diarrhea, and the protease inhibitors, although have improved, are linked to lipid abnormalities. So that's something else that we have to think about and discuss openly with our patients. The most important thing is recognizing what's the key things on the patient's mind and meeting them where they're at to come up with a medicine that they're going to take.
Yeah, I would just add from the health plan perspective, very similar. We obviously want regimens that work. We want those that are going to be effective and well tolerated. Certainly the most convenient regimens make sense. And if we're going to spend a significant amount of money on a per patient basis, we want to make sure that the patient's compliant with therapy as well. So to your earlier comments about splitting things up, if the patient's not compliant, obviously there's an additional expense both for the drug combination, but also the risk of complications. So, well, thank you very much. That was our final question for today. We want to thank all of our listeners for attending today's webinar. To be eligible for continuing education credit for today's activity, log on to www.naccme.com, that's NACCME.com, successfully complete the 10-question post-test and evaluation form, and immediately print your documentation of credit. This concludes today's session. Thank you, Dr. Worcel, and thank you all for attending. Have a great day. Bye now.